what? In this system, I can actually see where people join, which is fantastic. So whenever you start joining, okay, I see people joining on YouTube. This is fantastic. You are early, guys. It's 6 a.m. in Pennsylvania, and we're doing our DigiPath Digest. So, if you are there already, can you give me a comment that you hear me and that you see everything? Because it's in your system. So, if you don't, last time, even though I had a old system, I was like not having the microphone on for 2 minutes or 3 minutes, so that was not great. And but somebody told me in the comments. So, but let's check. Am I even live? Am I live? Is the question. And then I'll have to go into those live streams and cut the beginning off. But that's okay. Hmm. Let's see. Am I live? If somebody can let me know online if I'm live, that would be fantastic. And in the meantime, I'll try to share the screen and see if everything works. Okay, we are sharing, and I can I draw? Can I do stuff? Okay, here's my camera. Whoever is joining, just give me a virtual high, what's going on? Virtual high five. Let me know if you can hear me well, and let me know if you can see the screen. I don't hear anything from my team yet. Team Digital Pathology Place. Let me know if we are live. Maybe I can check it myself. Okay. Let me check. I'm gonna check it. And officially welcome you in 3 minutes. Okay, perfect. My team is letting me know that we are online. LinkedIn go. YouTube good. Okay, let's check Facebook. And in 3 minutes, we're officially live. So whenever you join, okay, I see one person on YouTube. This one person on YouTube, can you give me a comment? Can you give me a comment? Or Team Digital Pathology Place, if you can give me a comment so that we can see if this chat is working as well. That would be amazing. And I'm a little bit in between screens. And no comments yet. Okay. Still testing, guys. Still testing. So if you join, you are not late at all. You're totally on time. I'm just waiting for all the systems to work. Chatting with my team to make sure everything is working for you. And is this moving with me? Is the camera moving? Yeah, it is. Okay, good. And whoop, here, checking. Okay, it's working. One thing that's actually not so fantastic is the screen sharing and de-sharing. This is not so great here, but what I can do is to move this particular screen here. And maybe the sharing and de-sharing is gonna be better. Okay, I see some people joining on YouTube. How do I see? Okay, here is where everybody is. You, once you're here, let me know that you're here so that I can. Okay, it is 6 a.m. in Pennsylvania. Welcome back. Welcome back to Digital Pathology Digest, DigiPath Digest, our regular series. We finished the AI, 7-part AI series, I think one live stream ago. Mm, So now we're back to our normal papers. But before we dive into the papers, I have a couple of updates. So, first, when you join, and I'm going to be seeing if you are joining. Um, I should be because we are using a new live streaming system. Let's see how that goes. But basically, when you join, look at me and see if there is anything off in my appearance. And I'm going to let you know what that is after I give you a few updates. And obviously, if you are already here, let me know that you're joining because I need to see if comments are working. Okay, I see that Facebook is not working. I don't know why. So maybe today is not going to be our Facebook day. Um, so if anybody is on Facebook, you will not know that it's not working. You would have to go to a different link. But um, I'm just going to ask for a comment and give you the update. So, what happened recently? I was at the conference, but it wasn't the conference, a pathology conference or a digital pathology conference, because it was online creator conference. So basically, I went to Idaho to learn how to create better for you online. So that was something amazing. And I was able to go run out in the mountains every day, not every day, almost every day before the conference. And that brings me to one a video that's going to come out probably next week is the vlog from US Cap, where I decided, okay, let me go. Well, I run like on a semi-regular basis, now on a more regular basis. And at ASCAP, I went for a 5 mile run in Boston, and I it's part of the vlog, so you can see me running there. Then the next thing that we're gonna be doing during the summer before I go to Poland again, because in August I'm going to be in Poland again for the summer. And but before I go to Poland, we're going to do a couple of histology live streams. So just to review the tissue, to teach you how tissue looks like. So everybody who's a beginner in the world of tissue, histology, wants to learn how to recognize tissue, that's going to be a live stream for you. I'm gonna send it. So if you're part of my list already, you will know about it. If not, stay tuned, and I'll be sending out emails. Another conference is STP, and let me just. Um, okay, I'm not seeing your comments. That is very bad. That means, let's see, can I live stream chat? Shoot, I don't see your comments, guys. This is so sad. Uh, okay, well, let me open LinkedIn on the side and see maybe if there are any comments there that I can address. Sorry, guys, for that. Um, I don't know. I don't know. I don't want to do it because then I'm going to screw up the live stream. So let me just keep giving you updates. I hope you are there. I see one person on YouTube. So I don't know if I'm seeing you actually joining this one. We're going to figure out this particular streaming software as we go. But going back to my updates, next conference that I'm going to be at, it's going to be for my specialty toxicologic pathologist. That's going to be Society of Toxicologic Pathology annual meeting, and it's going to be in Chicago in 2 weeks, I think, on the week of the 23rd. Hmm, not sure how to get chat. Oh, that is so sad. I cannot chat with you. Okay. I'm gonna cry internally as I give you updates. Um, so maybe my team can let me know if somebody guessed what's off with me today, and I'm giving you a hint right now. So then Muse, Muse is a sponsor of Digital Pathology Place, and we created a lot of content at US Cup. There were several sponsored podcasts. So if you have not listened to their recent podcasts from their booth at the conference, and go ahead and check it out either on YouTube or on any podcast platform. But what happened with them? They launched their service for veterinary medicine. So that is super exciting. If you don't remember what they do direct to digital tissue imaging. And now this is going to be available for veterinary medicine. So if you're in the veterinary diagnostic space, um, check them out and see if that's something that would work for you and would be beneficial for you. Okay, just moving between. Okay, I see some comments. Okay, I see one digital pathology trailblazers. Oh, and I can even show it. I can show it. It looks funky. How how do I de-show it? Guys, bear with me for the um figuring out of the live stream. Anyway, so STP, who's going? Let me know in the comments wherever you are. I'm not seeing LinkedIn. I think I'm seeing YouTube. I see YouTube. So if you are in YouTube, let me know. Uh, STP, I'm going to be there, which is fantastic. And cool update that I have to give you because I've been using AI for content creation for this channel, for the blog, for basically for Digital Pathology Place. But obviously, there are powerful tools that are tools that are specific, could be used for literature research, right? And I started using them. One of the tools, I think I showed you this tool at some point before. Is Perplexity. Perplexity is a RAG powered search engine. So, RAG is retrieval augmented generation. So, the large language model, instead of just basing everything off the model training knowledge, it goes into data and searches the data and then generates based on this data. So I was using Perplexity for publications, and let me know if you have any experience with that. So a colleague of mine, Candice Chu, has created a publication workflow, and I'm kind of like adapting a little bit. She has different tools. One of the tools is Perplexity as well. And I've been asking Perplexity for references for specific things that I was writing. I'm currently working on a publication about validating our digital pathology system at work and almost at the finish line. So I was working with Perplexity, and Perplexity very confidently is suggesting references with a title, with a date, with everything, and even with the DOI, the digital identifier, digital original identifier. I don't know. So anyway, it shows this, and I'm like, oh, let me paste it. But to cite it, I need to like recreate the citation in my citation manager, and then I paste it into the citation manager, and my citation manager is like, cannot find this reference. And I'm like, why not? Then I just paste the DOI and try different ways to like click the link. And it turns out this publication doesn't exist. Perplexity invents publications. So when you use AI tools for references, actually like click on the link, check if the stuff that you want to reference is in the email. Sorry, not in the email, in the publication itself. Because it may be the case that it's like hallucination, even with RAG, even with retrieval augmented generation, which I thought was like the panacea for all hallucinations of AI. Anyway, we are still responsible for the content we create with AI. It's a fantastic tool. I love it, but it needs to be checked. And you figure out um, your like workflow to check the stuff. I am currently clicking all the links and that I need to click. Sorry, guys, I'm confused with my screens again. Mm, it's gonna be a little challenging today, but we can do it. I think we can do it. Okay, here, going back. Okay, now I just want to check if I can see you joining. I only see YouTube. Shoot. But I have a few people on YouTube. So keep commenting on YouTube. And if you're on LinkedIn or Facebook or anywhere else, just stay where you are if you can hear me, if you can see me. And now we can officially jump into our publications for today. Let me know if you're going to be at STP. Let me know if you're using AI tools for writing publications. Give me an AI for publications in the chat, because I would love to learn your workflow, how you're making sure that your AI assisted publication writing is actually accurate, and what are like your checkpoints for AI in that particular scenario. And let me share our publications today. Okay, when you see the screen, let me know. I will be assuming you do. Mm. Oh, did you figure out what's odd with me? I am wearing, let me de-share so that you can see my full face. I am wearing, actually, let me give you this update. I'm wearing two different earrings. They are, one is multinucleated giant cell and the other one is cartilage. And I did that on purpose because I have something. I have a bunch of earrings that you guys can get. Also, this pattern, the colonic crypt. So we have three patterns. The ones I have on my ears, multinucleated giant cells. Does it focus? Yes. Okay. And the cartilage. I'm gonna mess it all up. The cartilage and the colonic crypt with a special stain, Alcyon blue. So whoever is a fan of special stains, that's for you. I have a limited amount of these, only 25 per pattern. So if you're interested, just drop me a comment. I'm gonna be making them available for you in the store, in the Digital Pathology store. Let me share the store with you. Um, it's gonna be in the store, but I don't know if it's actually working yet. So what I would do, let me know in the comments that you're interested in getting them. I've been wearing them on conferences for quite some time, and they cause a cool reaction. They are very cool conversation starters. So if you are somebody who is working with tissue under the microscope, they may be a good option for you. And now, for real, let's dive into the papers, because I was like giving you updates for 12 minutes. That's too long. I hope you didn't leave yet. So now back to DigiPath Digest, and we're starting with figuring out the PDF. Yeah, let's start with that. Okay, YouTubers, if you can give me some comments so that I'm on task, that would be fantastic. And we're gonna be taking this one first. Are we working? Yes, we are. Okay, immunohistochemical biomarker scoring in gastroesophagus, esophagus, I don't know how to pronounce esophageal, esophageal, esophageal cancer. I don't think that's the correct pronunciation. Can computer help us? So, if you've heard me speak ever, you probably know I have a very strong opinion on scoring visually. IHC and in generally like visual scoring system. And my strong opinion on that is it's guesstimation. So if you can get a computer to help you, please do. So what happened in this particular publication was that obviously, the scorings are increasingly complex, but still the expectation is that the pathologist is going to do it, is going to score. So increasing complexity of cancer diagnostic has placed a growing burden on pathologists. I know when I hear about scoring, I'm sad because I know I'm not going to do a good job. It's going to be a guesstimation, especially evaluation of IHC biomarkers. And in this case, they were focusing on shoot, I should have researched esophageal. Let's call it esophageal, gastroesophageal. And um, for the podcast, I'll probably do a voiceover once I figure out how to pronounce it. Esophageal cancer, both adenocarcinoma and squamous cell carcinoma. And if you know how to pronounce it and can give me a phonetic comment, please do right now, specifically on YouTube if you can, because then I can see your comment. So, um, for this particular cancer, GEC, there are multiple prognostic and predictive biomarkers, and this meticulous scoring is difficult, time consuming, and suffers from inter and intra observer variability. This is the thing that I dislike for those scorings, very subjective. Often it's the best we can do, but a computer can do better. And we don't have enough pathologists to sit there and score. So the potential solution would be AI. Mm, and can AI help us in IHC biomarker scoring in GEC, gastroesophageal cancer? And they did a search in PubMed and Google, and by they didn't introduce the authors. Here, this is a group from Italy, Alessandro Caputo et al. And this was in pathology research practice. So what they did publication search. They did a search, and there was promise of AI for PDL1 and HER2, but that's not something you would always have in GEC, and the applications in GEC remain limited. Um, so well, let's develop some algorithms then for GEC. But the conclusion here is that although there are several algorithms for scoring IHC, and there are not so many in GEC, um, and AI would help us by alleviating the burdens of complex scoring systems and costly additional assays. So if we had that, that would be fantastic. We don't have that for GEC. So if somebody is working with the GEC, please develop it. Let me know if you're working in GEC. Okay, I don't know if my comments are not going through. Let me check with my team. Um, yeah, Team Digital Pathology Place. Let me know if any comments are on other platforms. And before the next live stream, which is going to be on Friday, for the papers and for histology probably on Wednesday. And we're going to figure all the comments out and everything, or we're going to revert to our old system. But now let's talk about the potential use of AI for atypical small acinar proliferation in prostate core biopsy. So ASAP and for prostate. So what is that even? Prostate cancer is the most common diagnosed cancer and also second leading cause of cancer death in the US. And the gold standard is examination of tissue from a symmetric uh, 12 to 14 core biopsy procedure by an anatomic pathologist. And there is something called atypical small acinar proliferation, and this is considered an indefinite diagnosis and may cause difficulties in clinical management. So you basically don't know, are you what's going on, right? It's atypical small acinar proliferation. So in this particular publication, what happened was that the authors, who were from, I don't know which institution because I have a different printout, but this was in Vircho's archives, and the authors did use AI to check against the pathologist. So what they did to investigate potential use of AI um, in this ASAP case, they, so is my camera following me? I don't know. I feel like I'm not in the center of the camera. Um, they used Paige Prostate. Paige Prostate is the FDA approved AI based digital pathology system. And it was used on images of 107 cores with an initial diagnosis of atypical small acinar proliferation. So I have my like questions about this like study design or like what they gained with this exercise, but they used the Page prostate and they had two pathologists blindly reclassified the course with a new diagnosis, benign or malignant. So this is something I don't understand. If you understand, please let me know, because they had this atypical small acinar proliferation. So they like, it was an indefinite diagnosis, and then they reclassified and like were forced to decide whether it's um, malignant or benign. Hmm. Okay, but anyway, they decided that it was either benign or malignant. For 80%, 85% of the cases for pathologist one and 88 pathologist two. So I guess in the remaining cases they didn't reclassify. And Page prostate resulted in diagnosis that was consistent in 85% of the course. So prostate doesn't say malignant, benign. Prostate Page prostate says suspicious and not suspicious. And then so it was consistent in 85% of the course, and the consistency rates were here 75 between the two pathologists, and 66 and 77 between the two pathologists, and 66 and 75 between Page prostate and each pathologist. So yeah, we are in the high 70s with one pathologist and the high 60 percent concordance. Yeah, how I say that we, if the pathologists agree a lot, it's like 70%, but in the 30% of the cases, they don't agree. So that's does not surprise me. But um, there was some degree of inter-observer discrepancy still, and the findings indicate that artificial intelligence was compatible with pathologist review. So here my like question or reservation is, but did you then somehow check with a different method? Can you even check for this? Because to me it's like, okay, uh, Page prostate goes against pathologists that are classifying something that is difficult to classify. I don't know where the added value is. Um, well, the good thing is that Page prostate performed like the similar to the pathologist, so that's good. But that was my reservation about this one. I would want to see, and I don't know if there are orthogonal methods to do that, but I would want to see, okay, then they stain these atypical acinar proliferation for some maybe like basement membrane disruption marker. There are markers that can, the IHC markers that can tell you if it's benign or malignant. And then compare this to the pathologist reclassification and prostate. So I don't know why they didn't do it, or maybe I'm just misinterpreting something. Let me know if you have any questions. I'm just gonna check with my team if we have any comments coming from outside. Let me know what you think about these earrings. If you like them, you can get them. Okay. Hmm. I'm not getting any information about the comments. If you're on YouTube, I know that you can comment because I think one comment went through. So just let me know where you're tuning in from. so that I see that you're there. I see a few people on YouTube still. Okay, good. Next paper. Let's do it, guys. Let's do it and go eat breakfast. Um, we have a paper about the development of a machine learning based model to predict urethral recurrence following a radical cystectomy. This was a multi center retrospective study and updated meta analysis. So, this was a retrospective study with like real cases and literature search meta analysis for this particular thing. And no image analysis was used, that was machine learning um, trying to compute uh, a predictive algorithm. So, urethral recurrence following radical cystectomy for bladder cancer represents an aggressive disease failure, and it typically results in poor survival. And so they tried to predict risk factors for this recurrence, urethral recurrence, to develop and validate an easy to use predictive tool for this recurrence, urethral recurrence in the region. And in the region, this is in China. This is a publication from China. And I highlight this easy to use because yesterday I was trying to find a software for reference management and AI based software. I tried like three different ones and then went back to Perplexity, who invents publications. So I couldn't use that one for reference management and to ask, hey, which one is the easiest to use? I found one. I will report once I have that publication finished. So anyway, so clinical pathological data from the patients who underwent RC, radical cystectomy, between 2010 and 2020 were analyzed, and they wanted to confirm independent risk factors for urethral recurrence. Um, and they did univariate and multivariate Cox regression to check that. They did an internal validation. They had a data set to train and data set to test. 80% of the data points was for training and then 20% for testing. And they developed this predictive model using the machine learning algorithms and evaluated the model performance by area under the ROC curve. Uh, and also accuracy, sensitivity, and other metrics like F1 score, Breyer score, and C index. F1 score, I'm familiar from image analysis. And the best performing model was selected. And they used so-called SHAP method, shapely additive explantation method, to calculate the contribution of each feature to the machine learning prediction. And they had several features that contributed. So let me show you what these features were. Um, they had, and also then they added the PubMed and Embase and Scopus databases for publications. And they had 473 patients, and they analyzed with a, they were analyzed with a recurrence rate of 8.24%. And then there was also concomitant carcinoma in situ, tumor multifocality. They were demonstrated to be independent predictors of recurrence or urethral recurrence. So concomitant carcinoma in situ, tumor multifocality, and also they they calculated their metrics area under curve that was 0.86 and in the training set and 0.77 in the test set respectively. And they developed an easy to use risk calculator tool that could be used online for this. um, and here were the risk factors that contributed. So, for example, transurethral resection, the TURBT, transurethral urethral bladder tumor resection, and then bladder neck involvement, trigeminal or prostate involvement, tumor multifocality, we already talked about this, lymphovascular invasion, and diversion type. So, diversion is a surgical procedure to divert how the urine flows. So, the type of this procedure was also important. Also, concomitant carcinoma in situ neoadjuvant chemotherapy or adjuvant chemotherapy, and these were all significant predictors. Um, and as we said, tumor multifocality and concomitant carcinoma in situ were independent predictors of their recurrence, and they developed an easy to use online calculator too. So, like a lot of words for a cool thing that can be used based on all the clinical information, all the patient data. So, basically, you can have a machine learning model that calculates this. mm, Maybe with an LLM, they didn't use large language model here, or at least they don't talk about it in the abstract. But what you could do, you could leverage LLMs, RAG, to get this information to the machine learning predictor and get the prediction without like having to input it manually, which would be fantastic. So here, go AI. And we have one more. Oh, I see some comments. Okay, beautiful. Let me show the comments. Let me 1 second. 1 second. Mm, okay, we have somebody from upstate New York. This is amazing. Thank you so much for joining, Said. I am honored to have you here. Like every morning I go live. I'm so honored that there are people, and upstate New York is my time zone. So it's 6:31 for you. Thank you so much. Thank you so much for joining. Okay, our last paper for today before you can go get our coffee. I don't even have coffee. I just have water today. Okay. Reticulin framework assessment in neoplastic endocrine pathology. I saw this title and I'm like, so cool because you can do a special stain for reticulin and use image analysis, AI powered image analysis, which is like my favorite thing to talk about. So let's talk about it. Give me 1 second to cough. Okay, you should be hearing me again. So, this reticulin framework, this is composed of mainly type 3 collagen. It's a framework that uh, holds the cells together. It's an essential structural component of biological tissues. And reticulin stains, specifically, particularly silver based methods, um, they enable detailed visualization of reticulin framework alterations. And I'm going to Google reticulin stain for you and share it with you so that you can see it as well. Uh, this is a good one. Let me share. Stop. Share screen. Reticulin stain. Share. Uh, shoot. I want to show you this. Is it gonna? It's not showing. Sorry, guys. Okay. Let me share again. I can do it. We can do it. Don't go. Stay with me because you're going to see the reticulin stain. Mm, this one. Yay. Okay. So now you should see reticulin stain and you see this black stuff. This is the, you should see my, okay, here I can do this. So all this black stuff here is the reticulin. This is this type of collagen, type 3, that is stained with silver stain. Silver stain makes stuff black. So all this is reticulin. So I see that and I'm like, it's easy to see, meaning it's going to be easy for an algorithm to classify. And still struggling with my screens. Those who don't have patience with me on the live stream, they will just go to Buzzsprout, or Buzzsprout is my podcast host. They will just go to the audio podcast because my team is gonna edit all this nonsense of me trying to figure out stuff. Okay, let's stop sharing this one. Let's go back to our paper, and we're at the finish line. And if you're still here or just joined, you can watch from the beginning, but let me know where you're tuning in from in the comments. I see some. I'll figure out why I don't see all. So you've seen the reticulin stain, and it is a quick, low cost, and reliable solutions for highlighting quantitative and qualitative changes of reticulin framework. So you can imagine you have this like regular framework where the cells sit on this framework, and if we have like disruption of this framework means cells are out of whack, which is kind of an unofficial definition of cancer, where they start growing like crazy, so the framework is distorted. uh, so this distortion of the framework, changes of the framework, have been variably associated with neoplastic and non-neoplastic conditions. Um, so this is an overview of reticulin stain applications and reticulin framework assessment in endocrine and neuroendocrine neoplasms. And we're talking about the pituitary, parathyroid, adrenal, and some other neuroendocrine systems. And in pituitary neuroendocrine tumors, reticulin framework loss serves as a distinguishing feature between normal and neoplastic. So to me, it's already, let's make an algorithm for that. So between normal and neoplastic adenohypophysis. And then when we talk about parathyroid neoplasms, including adenomas, atypical tumors, carcinomas, there is varying degree of reticulin framework disruption. And similarly, adrenocortical neoplasms. And so this reticulin framework is important for malignancy assessment as defined in the reticulin algorithm. So there's a reticulin algorithm, but it's not like a computer algorithm yet. This is something that incorporates the reticulin framework alterations along three WISE criteria, which totally could be a computational algorithm. Maybe it's already computational. My understanding was this is visual. So we check for necrosis, high mitotic count, which is over 5 per 10 millimeters square, and venous invasion to vein invasion of the cancer cells into the veins, and specific reticulin framework patterns help distinguish the different morphological subtypes of bilateral macronodular adrenocortical disease. That's a mouthful that requires somewhere. Mm. Pheochromocytomas and paragangliomas display a range of reticulin framework patterns. And finally, different neuroendocrine neoplasms exhibit also variable reticulin framework integrity, with a more significant disruption observed in high grade carcinomas, and high grade are more out of whack. So the reticulin is going to be also uh, more disrupted. It's going to be all over the place. And here is my favorite statement. So maybe we can change color for my favorite statement is advancements in digital pathology and artificial intelligence offer promising avenues for automated reticulin framework quantification, and that would further improve our assessment of this. So I would like, if I was a researcher here, the next thing I would do would be to scan these images and develop an algorithm, maybe like a weekly supervised one. Let me unshare this. Okay. So I would do a weekly weekly supervised, where I would have the image of the tumor with the reticulin stain, and then the diagnosis or classification malignant benign, whatever you want to use this algorithm for, like a screening one, for example, malignant benign. And I would train it and then run it on these stains if they are cheap and used on a regular basis. Why not? Let's have an algorithm do that. That these are all our publications for today. And if you're interested in the earrings, you can find them in the store digitalpathologyplace.com. Mm, can I message you this link? I want to message you this link in the chat. I don't even know if you guys see my chat. And honestly, I don't know if it's set up well in the store, but you definitely can click on this stuff in the store. Let's click on these guys. Do they open? Yeah, you can see the patterns that we have. If it's Father's Day, so I don't think this is gonna be a Father's Day in the US, a Father's Day gift, but it could definitely be a Mother's Day gift, or whoever wants to use them, you can. There's gonna be some more stuff coming up, but I just thought it's going to be nice to make them available for you. They are sparking conversation, and I don't think there's too much cool stuff from under the microscope in the jewelry department. And I always see like DNA, some protein, um, i- jewelry, like the DNA helix is always on some necklaces and stuff, but nothing from histology. So I thought that would be something that you might like. Thank you so much for joining me. And Wednesday, probably this Wednesday, there's going to be histology workshop, histology live stream. So if you're interested in that, drop me a comment as well, even if you're watching the replay. If histology is something you want, let me know. Specifically, those folks on LinkedIn, because I don't know if I want to stream that to LinkedIn because it's more like educational. So I was thinking about Facebook and YouTube. Let me know if it even matters to you. I know several people are joining on LinkedIn. And next Friday, we're going to be reviewing the next papers. So honored and so happy for you to join me at this funky hour. And I'll talk to you in the next episode. Thank you so much. Have a great day.